So this brings me on to our next discussion, an important one. Um, I'm sure you've guessed it by now, and I'm sure you can have a look at the agenda as well. This is going to be about telehealth 2.0, building that robust structure. It's time now for some stimulating conversations from our side. On the screen, we'll have with us our array of experienced panelists. We're just going to be taking up the virtual stage. Allow me to please welcome Manish Ranjan, the co-founder and CEO, Nano Health. Well, Manish is the one who believes in user engagement model with the right blend of human touch and the technology. So the two important T's out there. And he believes that he can really revolutionize healthcare as we understand today. So great, that seems interesting, that vibe of confidence altogether, Manish, for you. And through Nano Health, you are really changing the reactive and the fragmented healthcare to a proactive, to a continuous, and also a coordinated healthcare. So that feels very enlightening to know, and hoping to hear some more perspectives on that note from you, Manish. And there's a tweet that's coming in saying, "Hi, Manish Ranjan." Great. So our audience is greeting you as well. And we're all set to invite up next, very cordially, Naresh Hasija, the Vice President at Viatris. Well, more than 19 years of experience for you, Naresh. You've launched branded formulation, proprietary brands in the private market access, government, healthcare, policy influencing, and the key accounts management all at the same time. Well, you're very good blend of experience in private and the public market that shall help us, pave the way when we talk about telehealth, right? And with that, welcoming you and also your co-panelist, Gautam Khanna, the CEO, Hinduja Hospital. Well, Gautam, you're also the co-chairman at FE Health Services, and you are very well known in the industry for your cross-functional, the team leadership, the business strategy that you bring about. So thank you, Gautam, for joining us. And all of you would be in conversation with your own moderator for the panel, Dr.K.Ganapathy, Director, Apollo Telehealth Services and Apollo Telemedicine Networking Foundation. Well, Dr. K. Ganapathy, very, very eminent figure. Yes, I am very consciously adding the two very's to it. Well, the past president of Neurological Society of India, former secretary of Asian Australasian Society of Neurological Surgery, a former adjunct professor at IIT Madras. Dr. Ganapathy has initiated not one, not two, not three, but several patient empowerment programs, along with many other accolades to his credit. It would be insightful and it would be a way to become wise, I should say, as I hand it over to this panel. Over to you, Dr. K. Ganapathy.
Good afternoon, ladies and gentlemen. It's indeed a privilege to moderate a panel discussion on Telehealth 2.0, building a robust structure. I belong to the BC era. I'm not talking of before Corona or COVID. I'm talking of before computers. When I entered the medical profession 53 years ago, there were no computers in healthcare at all. Those were the days when healthcare was essentially a doctor-patient relationship with some auxiliary support staff. The very fact that none of the panelists are clinicians shows that today, healthcare depends to a very large extent on policymakers, medical and business administrators, technologists, and engineers. There is no doubt whatsoever that this group has played a very major role in the growth and development of modern healthcare. However, belonging to the Jurassic Park, so to say, I am sometimes concerned whether the present doctors, medical students have to be reminded that even if you are tech savvy, even if you're conversant with information and communication technology, A doctor is still a doctor and a doctor from the beginning to the end. He should understand that tender loving care, TLC as we call it, is still important. I honestly believe that it is possible to wipe the tears virtually. One should empathize, sympathize. Your body language is critical, and you must treat the individual, you must treat the family, not just correct lab reports or treat CT scans or MRI. Lars Lexer, the inventor of the gamma knife, which 50 years ago was then healthcare's most sophisticated technology, he said, and I think it's as relevant today as it was then. I quote, "A fool with a tool is still a fool." When you have a hammer, everything around you looks like a nail, particularly so if the hammer is very expensive. I really believe that today the time has come for all of us to cooperate, and I'm delighted that I have with me a very distinguished panel of people who have bring to them diverse experiences. I will start with Mr. Manish Ranjan, co-founder and CEO, Nano Health, and alumnus of IIT Mumbai and ISB Hyderabad. Nano Health provides proactive and continuous care for managing chronic conditions. We all know that NCD, non-communicable diseases, is today the killer. Though COVID is getting all the attention, literally 100 pandemics have been in existence far before the COVID came. And it's even more important that in the current intra-pandemic and the post-pandemic era, we should not lose sight of what could be totally preventable and treatable NCDs. Manish, could you share with us how you in particular use technology to combat NCDs remotely? This entire discussion is about remote healthcare, telehealth. Personally, I like the word telehealth rather than telemedicine because we are looking at promoting wellness the e-way. Doctors of the future are not going to diagnose and treat. They are going to prevent and keep you healthy and happy. Could you go ahead and enlighten us on this? Over to Manish.
Thank you, Dr. Ganapathy. I mean, it's really a pleasure to be among such esteemed panelists. For Nano Health, when we were imagining the healthcare, right? So we had we are lucky enough to born a little later. So basically, we could imagine what big changes has happened in other industries. And when we looked at healthcare, we said that what can actually taken from other industries and can be implemented within healthcare. My dad is a doctor, runs his own hospital, so I also had the luxury to see it firsthand. And when I started on this journey, the most important thing which I noticed was the moment patient leaves the clinic or a hospital, there is a very little interaction that is there between the patient and the doctor. And and so I figured that care coordination is a big challenge between any disease, and especially when it comes to long-term diseases like diabetes, hypertension, then the problem becomes many times bigger. And when we started looking at it, when we went that okay, now how do you solve this problem of care coordination? Then we figured that there is actually very little to almost no health data available in the clinic or the hospital, which based on which actually we can start doing the care coordination. So the first step, we had to reimagine the EHR, where to capture not only the basics, appointments and financial billing data, but also the health information. So we had now different kind of health data, be it questionnaire, be it qualitative, or be it even the lab reports coming in into one EHR. Then the doctor prescription going into one system. So as the first step, what we did, we digitized all kind of different health information into one system where we can actually see a 360-degree health profile of an individual. And then on top of that, we built what we call as a recommendation engine, which for every activity that happens, it recommends based on the various parameters what should be the next activity that needs to be done. And that we have seen a very simple, interaction where identifying someone's measuring hypertension, blood pressure, every month, making sure that, the thyroid is being, measured, profile is being measured every 3 to 4 months for someone who has a huge disorder, or bringing back someone who is hypertensive, whose blood pressure, goes very high, in a simple follow-up, that makes a huge difference in two ways. One is basically the patient becomes a lot more healthier, and actually, even the services wise, the patients are actually consuming the services at the right time. So it's a win-win for the entire ecosystem. And what you mentioned, the most important thing is the doctors, right? I mean, along which the most important piece on one side of the entire telehealth piece. So we also work very hard to make sure that we are not only showing the data to them, but also bringing some analytics to them, where their diagnosis and where their next step, identification of next step for the patient becomes easier and simpler. And we're very proud to say that even when the COVID hit, we could repurpose the entire solution to, and what happens in, let's say, in 14 years in diabetes or hypertension, we can actually shrink it down to 14 days. So we could not only capture everyday trends, symptoms of the patients who are suffering from COVID, but even for the doctors, we could actually show that within the 5th day or 6th day, this is the 6th day of the patient, and this is the trend which the patient symptoms are following. And I mean, we have often heard even from the doctors that I mean, like, we are at this point of time getting more data for about the patient than when I'm standing right in front of the patient. So I mean, I really believe that for some of the specialties, we are already seeing the trends in the developed markets, especially for chronic care or for follow-ups. I really believe that this is going to be the next lot of the current flow is going to move online, because it's a very convenient for the patients as well, and we are already seeing the requests coming from the patients from that front. So really excited about the future.
Thank you, Manish. I know it is difficult in 300 seconds to tell all that you want. I was particularly impressed with your take-home message: care coordination, health informatics, qualitative and quantitative data analytics, health information, health electronic records, and particularly what you mentioned about a 360-degree approach and digitizing all the information. Now, these things are going to take time. You are not going to see the results overnight. It's going to take years, not even months. And I do hope that young people like you persist on it and don't get disheartened even if you don't get these results immediately. We require one single word: digitization of healthcare. As I told you, I belong to the Jurassic Park, but I am seeing in the last couple of years how digitization has made all the difference. Thank you. Thank you once again.
Thank you so much.
I now call upon Naresh. Naresh is a vice president at Viatris, a bachelor's degree in pharmacy. During the last 2 decades, he has been associated with launching of many branded formulations, proprietary brands in various clinical disciplines. Most of us, when we talk of the health community, we sometimes forget that, yes, theaters are important, surgeons, physicians, ECGs, echo, CT scan, MRI, etc., etc. But ultimately, finally, it is a medication which is most important. The most qualified or experienced or brilliant doctor is of absolutely no use unless the drug which he prescribes reaches the patient. And an important thing is startups. One of the major achievements in the last couple of years, I also happen to be involved with several committees of the Government of India, Department of Biotechnology, BIRAC. I have personally reviewed many proposals from startup companies, the Make in India initiative, Go Digital, etc. I think startups are equally important, and I always congratulate the young entrepreneurs who are prepared sometimes to take a beating. They're so passionate about it. So Naresh, can you tell me that how do you see the big, very well established international global organizations in the pharmaceutical industry. How do you see their role? Do you see them as hand-holding you, or they are competitor to you? Do you think you can live together with them? And before I forget, one more question I would like to ask you is, you are aware that after the notification of the telemedicine practice guidelines on March 25th last year, e-prescriptions are now a reality. I am very familiar with all the regulations, legal aspects, but as a person who is in the other end, who probably receives e-prescriptions and dispenses e-prescriptions, I would like to know whether this e-prescription has really made a difference. What is the utilization now compared to what it was just 1 year ago? Over to you, Naresh.
Thank you. Thank you very much, sir. I think it's a pleasure to be talking to you. As we have seen, you are really stalwart in telehealth, and the kind of work you have done, I think all of us are very well familiar with. Coming to your question, sir, we as a pharmaceutical company always think to be a healthcare company. So the global approach, what we are carrying is we wanted to be a good, large healthcare company. For that, we have started recently, we've created a global gateway where we would like to bring all the credible solutions of startups, mid-ups, and maybe some mature companies who can utilize our expertise across the world. So this is what is all about our global gateway, where we have, what we have done is we have merged all our expertise of each country, and those expertise can be utilized by a startup based out of India, a startup based out of Ukraine, a startup based out of Russia, wherever it is. But what we do is, we are right now also in touch with some of the mid-ups where we want to take their solutions to a next level. So, and they are also we are very excited with this newer solutions, like your what we are today we are talking about telehealth, and as well as your in telehealth, when you see data and then you see AI, then you see machine learning. So we are right now in India evaluating some of these solutions. We are working with some of the partners. Only thing, and coming to your second question, e-prescription. Wow, this is kind of a dream true when it came last year. And sir, we have started seeing a lot of difference in this space. We always used to dream in telehealth, primary and secondary care, if at least primary care, if can come on tele, and patient can be prescribed. And I think by the time patient reaches home, medicine also reaches dispensed and reaches home to the patient. So I think we can reduce the load of primary care on our healthcare system by government regularizing e-prescription. So we see some change which has just started, sir, has started coming in healthcare industry with e-prescriptions. Over to you.
Thank you very much. I think if we have time, we'll come for a second round on prescriptions. Now it's my pleasure now to interact with Mr. Gautam Khanna, an alumnus of IIT Kanpur and IIM Kolkata. He is currently the CEO of the very well-known Hinduja Hospital in Mumbai. For the last 31 years, he has been managing diverse businesses in India and overseas. As co-chair of FE Health Services Committee and president of the Association of Hospitals, Mumbai region, I believe that he could play a very major role in the development of policies. I mean, though I have been a neurosurgeon for 45 years, over the last couple of years, I have realized that policy making, health economists, regulations, etc., are as important or probably even more important than upgrading all the fancy technology which we use. Mr. Gautam, I would like to know what exactly FICCI is doing in the field of telehealth, e-health, number one, and what Hinduja Hospital, I would guess, represents to some extent the corporate hospital culture in the western part of India. And I would certainly be delighted to know what is your policy, what are you planning, like the Kaiser Permanente, for example, the world's largest chain of hospitals. Even before the COVID came, I understand that 40% of their clientele, which runs in several millions, consultations were virtual. I understand that now it has reached a staggering figure of 75 to 80%. Similarly, Cleveland Clinic, Johns Hopkins, most institutions, Apollo hospitals, for example, most of the big institutions are doing this. And I would looking forward to your response to this. Over to Mr. Gautam.
So, Dr. Ganapathy, thank you for the nice introduction. So quickly to talk about the role of what we do in FICCI and through Association of Hospitals. So one of the things which is done is that, as an association, we collect information from and inputs from all the stakeholders, whether they are providers and people who are suppliers. And then, so we have done that and then developed some draft guidelines and presented it to the government before. So what happens is we continuously interact with the government and give the view of the industry on what policy changes are needed or what are the things which need to be tweaked in the policy which has been announced by the government so that it can help the patients. So that has been going on and the papers have been submitted to the government. So that's one thing on the FICCI side. Regarding the Hinduja Hospital. So, when COVID hit us and you talked about 25th March, I have to say this, that we've been trying for, telehealth guidelines and teleconsult guidelines for years and years. It didn't work to our satisfaction the way we wanted it to be. But suddenly, because of the regulations, it worked. So to give you an idea, how we utilize the telehealth is that till date, we have had video consultations from patients across 260 cities in the country. So now for you in Apollo, it may not be much of a difference because you have a national presence, but think about us who are presently in Mumbai. And from Mumbai, we are able to reach patients in 260 cities or the other way around. Patients from 260 cities, remote parts of the country are able to reach us. So that's one thing. The other important thing is that during COVID time, almost all consultants, at one point in time, 100% consultations were teleconsult or video consult. And once things have opened up, it has come to a stage where 25% are still video consults. And you'll be surprised to know that within the city of Mumbai, around, many patients prefer video consult because of the convenience, because of the, no commute required and so on and on, because it's regular follow-up or, just sharing the reports or whatever it is. So I think it is something which is here to stay. And we've already provided, in our teleconsult solution. So patient and the doctor can log in from anywhere. They both can access their electronic records, which are with the hospital. You can have the e-prescription, you can take a printout. So everything is there, whatever is there in the physical OPD, except the physical touch. So I think it is here to stay. And as a hospital, we are going to embrace it. The other opportunities I want to just talk about the telehealth. Sometimes we think telehealth is only consultation with a doctor. But, when this COVID crisis started, think about it, the patients who were anxious and they didn't know what to do with the hospital, whether to get admitted, not to get admitted, what is to be done, whom should they talk to, because nobody is available to talk to. So, we created a teletriage line with the nurses. So nurses would talk to the patients and the existing patients who are planned, and explain to them, understand their condition and decide whether they should come for surgery or procedure or whatever, or stay at home. So that's one example. The other thing is when we found that the guidelines require 14-day isolation at home for patients. Now think of the anxiety of a patient who is at 14 days at home with COVID. He has no access to a hospital, and many don't have access to a doctor or the doctor of their choice. What do they do? So, we did this, again, all digital solution, that for 14 days, we'll have 4 video consults with a doctor. Nurse would monitor their vitals every 8 hours for 14 days. We had a counselor consult. We have a dietitian consult. And, in monitoring the data remotely. So, that I think is going to stay, because that has been pretty successful and liked by many, many patients. The other example of telehealth And I'm glad, Dr. Ganapathy, you mentioned from telemedicine to telehealth, because I think the hospitals like us and like yours, today we've been treating the sick people. So tomorrow we will have to probably treat the health of the community. So we will be responsible for health of the community. And for that, things like prevention, education, and we've been doing that digitally. We've been doing lots of videos, lots of seminars, and things like very simple application in a hospital of digital is that a patient in a COVID, imagine COVID when the patient's relative is not allowed to meet the patient, doctor is not meeting the relative. So how do you discuss and how do you handle the anxiety? So simple things like putting an iPad in both the places, so they talk through iPad and things like that. And my view, Dr. Ganapathy, before I just close, I think the way telehealth, and I'm looking at telehealth the way you are talking about it. I think telehealth, the way I think Manish talked about the data, he's collecting the data. If the way it is going to go forward is if we have a predictive ability, there is some analytics, and of course he talked about the machine learning and so on, but if we can use that to have some kind of a clinical decision support systems for our hospital staff, and that will be a real continuation of telehealth in my sense. It cannot be only consultation, and is all aspects of the patient journey and the care continuum. So I think it is here to stay, and all of us need to adapt to that. Dr. Ganapathy, thank you so much.
Thank you, Gautam. Honestly, I'm absolutely thrilled to know that this is going on. For the first 15 years, when I was doing telemedicine from 2000, it was spent in just evangelizing. People laughed and ridiculed. The COVID has totally transformed everything. I have a request to make to you, Gautam. It can't go, Hinduja can't go higher than you. You are the CEO. Please ensure that your staff share this very, very valuable information with all of us in the form of scientific articles. See, a major problem in India is I'm very familiar with the published literature, not only in India, but in all over the most countries in the world. We honestly have done much more work than most people in most countries, but we just don't have the publish or perish attitude which the Western doctors have. And most doctors here are so handicapped by lack of time. Please entreat you to become an institutional member of the Telemedicine Society of India. Hinduja's presence will certainly give a tremendous fillip to the growth of telehealth in the not only in the western part of the country, but in other parts. So if the data can be analyzed in detail, the 260 cities you mentioned, the people in Mumbai itself, etc., a beautiful paper can be published. It is time that Indian telemedicine, we promote ourselves in the rest of the world. And the only way we can do that is by publishing. So please do consider my appeal as a past president of the Telemedicine Society of India. I once again request you to please help us promote telemedicine. Thank you, sir.
Wonderful suggestion. Thank you so much.
I had mentioned in passing when we started this panel discussion that e-governance, m-governance is absolutely required. I'm not going to bore the audience with statistics and details, but not in the lifetime of my great-grandchildren will there be enough doctors, nurses, hospital beds, and what have you. It's just not going to happen. The only way to divide the urban-rural health divide is by using digital technology. TRAI's recent report, the Telecom Regulatory Authority of India, recent report said we have crossed the 1 billion mark. 1,000 million mobile phones, and almost 45% of them are smartphones. More people are accessing the internet today through their mobile phones rather than through the old-fashioned desktop or even laptop. And it is absolutely remarkable that the National Digital Health Mission, the Government of India's plan, or the National Digital Health Mission, there is no difference between the public and the private sector. And I am confident that in my lifetime, I am going to see somebody from Hinduja, somebody from Apollo, somebody from Justlo, Max, whatever it is, go into a community hospital in a small town, give his UHID number, and with due authorization and security, the doctor at the district hospital anywhere in India, any of the 640 district hospitals, will actually be able to download not just a CT scan, an MRI, or a laboratory report, but even if he wants, look at the histology of a breast tumor or a brain tumor. This was absolutely fantastic. And the fact that the government is extending this remarkable facility to the private sector, I think speaks for itself. Mr. Gautam, what do you think about public-private partnerships? Apollo is actively involved in very major public-private partnerships. We do almost 10,000 teleconsults every single day for the last 2 years in 8 different states. I mean, as a very experienced professional heading a big hospital, what do you think? How do you think we could collaborate more with the government so that there is a win-win situation for both?
So, Dr. Ganapathy, firstly, I think the public part PPP is a good model to have, because there are some aspects which are present in government which the private doesn't have access to. For example, the access to the vast population of the country, and there are some specialists which are present in private which government may not have easy access to. So I think there is a win-win for both. Now, the only concern I have, and I think we need a resolution of this, is that what is the monetization model for this? Because somebody has to pay for it. Now, if not, just to be a little practical about it, the purchasing power or the affordability in a small town, tier 2 or tier 3 town, is much less than what it is in places like Mumbai. Now, the patient in the tier 3 town is actually the one who needs the consultation, but his paying power is little less. And the consultant in a large city is the one who can provide the service, but his expectation is of much higher fees. So there is a big mismatch. So there is a gap which we have to figure out how to do it. Now, that can be done an easy way, and I just think of it all the time, is, the company CSR money, which is going for all kinds of things. Maybe we mandate it to the hospitals and say that, listen, you will give to this hospital for doing teleconsult through PPP model. So, suddenly it is viable for hospital, for the consultant, and for the patient. So that's one way of doing it. Second thing is that even if it is not possible to do this, we can still say that for, at least in hospitals like ours, which are, we are a trust hospital, we can do saying that X number of consultations you will do free or at reduced rates. So that's another option, which not everybody will like it, but there are some people who will accept it. And there are many, many doctors in the country who are willing to serve the country. So I think there is a possibility. The third thing, which if it doesn't work like this, then the other way of doing it is that instead of doing one hospital with the government, you do a consortium of hospitals, whether some 5 hospitals, 10 hospitals, 20 hospitals, whatever. So as a private hospital group, you are providing the services so that you are able to give the numbers which are required by the government. Now, I don't know what will work, Dr. Ganapathy. I don't know about this, but I think this is a field where all of us are learning, and your experience, actually, I'll be happy to hear from you about Apollo's experience, how that PPP has been viable and how the consultants are able to deliver that service. But I think some of these models can be tried. Thank you.
Thank you. There are 2 questions in the chat box. Before I go to them, the answer to you is one of the techniques which I have adopted, which I think has contributed. Most consultants get their kick out of it by seeing a number of patients. So the monetization part reduces when I have an opportunity to see 4, 5, 7, 8 patients. And so we don't pay our consultants per patient, we pay our consultants per hour. So I get together 5, 8, 10, 12 cardiology patients and I pay the consultant per hour. Most consultants do not look at the watch. So even if it exceeds that allotted time by 15 or 20 or 25 minutes, it doesn't really matter. So this way, the patient pays only 1/3 or 1/4 of what he or what he would normally pay. And even a very senior consultant at Apollo Hospital, for example, he has a tremendous satisfaction of being able to help a large number of patients. At the same time, he gets some token honorarium at this. So this has worked very successfully for us. Of course, there is a lot of operational details, logistics in getting 3 neurological patients or 4 orthopedic patients, etc. But then teleconsultation by definition is not emergency, though we do have an emergency unit as well. I think, sorry, I lost the chat. Can somebody read out to me the question in the chat?
Right.
I don't get the chat here now. I don't know why.
Yeah, one of the question is how do you build confidence in patients where the culture is to meet and talk to the doctor?
Yeah, that's a very good question. And as I told you, this is where people of my generation come in. See, it is absolutely important. People are not. I always tell that selling healthcare is not like selling a pizza or booking a ticket on your Indian Railway Transport Corporation or on your Air India or any airline. Selling health is totally different. You need to empathize with the patient. You need to sympathize with the patient. Body language is very, very critical. Listen, listen, listen. I have personally given about 3,000 consultations in the last 15 to 16 years in neurosurgery, neurology. And of course, maybe because I'm not as busy in the theater as the younger doctors are, but I do make it a point not to look at my watch, not to be in a hurry, to spend at least 7 to 8 minutes listening, and talking to the patient. This is all that is required. Unfortunately, people who use telemedicine, particularly the younger group, the meter starts ticking and they're genuinely super busy. They're not able to spend time. So if your body language, if that wow effect has to be created, the patient must say, wow, look at that doctor. He listened to everything which I said. And I personally think the biggest brand ambassador, if you want telehealth to increase 10x or 20x, it is not COVID alone. It is not the government of India regulations. It is not having monetary benefits. It is the patient, and the patient. The patient must go and tell his neighbor, his friend, his relative that I consulted a doctor on a small screen on my smartphone, or I consulted a doctor on a big 42-inch screen. And honestly, I couldn't find any difference that the doctor was not with me. I thought the doctor was really with me. That is the impression. Technology allows you to do that. But then technology is all, I always say in my talks that technology is only a means to an end. It is not an end by itself. We need to remember that. Tender, loving care, empathize with the patient. That will solve all the problems. Naresh, can you tell me a little more about e-prescriptions? I presume I do give a reasonable amount of e-prescriptions, but I very strictly follow the rules since I'm aware of these rules. But what are the practical problems which you encounter when you get an e-prescription, to dispense an e-prescription?
I think what we saw was a very, very good flow of e-prescription during COVID, where people were not moving out, and our retailers we were watching very closely how retailers are behaving with e-prescription and what kind of changes we need to see for tomorrow. We saw that the problem was the earlier problem was regulation. The second was when you know that there is no other solution, you are not going out. I think retailers were able to dispense these e-prescriptions. Prescription has to be like, there were two kinds of prescription we saw initially. One was, of course, doctor was writing on the WhatsApp, answer of a question, answer of a problem. Okay, this is your disease, and this is what I can see that. And then in that case, this doctor was writing. So I think the retailer was not able to dispense those medicines till we are not getting it on letterhead of the doctor. So, sir, overall, what we saw was there was a big upsurge of e-prescriptions. Now we see a lot of things are normal. It is not that way. It is not in that magnitude the way it was during the COVID wave 2. Over to you, sir.
Thank you. There are two questions, one from Mr. Amit and one from Dr. Jitendra, were very, very practical, down-to-earth question. Internet coverage is not strong where we need medicine to really go. How do we overcome this problem? a similar question asked by Dr. Jitendra. I wish I could tell you the answer, sir. Obviously, this is not something which can be answered overnight, but I would just like to remind you that compared to what internet was available 20 years ago, 10 years ago, even 2 years ago, I think we are making remarkable progress. It is just not possible to provide internet connectivity to 645,000 villages. Tier 2 cities, the big towns have all got internet. Now, again, when we say internet, adequate internet, just enough internet. See, when I started telemedicine 20 years ago, I was using 64 kbps. And then for several years, we used 128, 256. Then we came to 1 Mbps, 5 Mbps. Today, most of my departments in the country, we have 100 to 120 Mbps. Now, this is just a question of time. We have to be patient. I'm very confident BharatNet is making enormous efforts. The COVID has partly set it back, but I'm very sure within 2 to 3 years, 75 to 80% of a huge country like India will be covered by the internet. Number one. Number two, instead of instead of traveling 50 miles to get an internet, as it was several years ago, I have gone to many villages in distant parts of the country as part of my telemedicine activities. And I do not think today you have to travel more than 5 kilometers, maybe 8 kilometers to get reasonable, decent internet connectivity. And I think it's far easier to travel 5 kilometers than to travel 50 or 100 kilometers. So we are getting there. We just have to be a little more patient.
I would like to add another point.
Yeah, please.
Yeah, I mean, one thing is the internet speed, but also what's happening is the new technologies that are coming up, especially for video consultation, etc. You know, they require a lot lesser bandwidth. So they are also becoming more and more efficient, so that you know, the more even with a lesser bandwidth, we can still go ahead and provide you know, among the best teleconsultations, telehealth possible.
Absolutely right. I just remembered, I always used to say, it is not Wi-Fi which is important. It is not WiMAX which is important. What is important is YFM. I don't know how many of you have heard of W, small I, capital F, small M. I've been using this terminology for many years. What is in it for me? Let us not be hypocrites. Let us accept the fact. Unless there is an incentive, unless there is vitamin M, unless there is monetization, or there should be a carrot and a stick, there should be a disincentive. Incentives are far better than disincentives. The most important thing, if you want telehealth to exponentially grow, radically transform, is what is in it for me. With all respects to the app developers, with all respects to the mobile network operators, to the hardware, software producing companies, etc., they get all their revenue upfront. When we set up a telemedicine unit, we have to pay the entire amount upfront. But it is only the poor healthcare provider, as Gautam very correctly mentioned, particularly in a public-private partnership. Even though the contract sounds very nice, it takes several months. It may take years for us to actually get the money and for the money to be disbursed. So we need to develop a business model. All over the world, telemedicine today is being held up not because of lack of technology, not even because of lack of investment. We can always get capital from somewhere. As Gautam mentioned very correctly, it is a business model. So we need to understand there has to be an ROI. Of course, the ROI will be nowhere near what you get when you invest the money in a CT scan or in a cath lab, perhaps. But still, you cannot do telemedicine unless there is a return on income. In other words, for it to be sustainable, it has to be revenue generating. If I wrote a paper recently on the business of telehealth a few months ago, I did an extensive survey of the literature, and I found that 5 years ago, 90% of telemedicine units which were commissioned died a natural death within 3 to 5 years. There are less than 10% of telemedicine departments worldwide continue to thrive only because they have a business model. So unless there is and when I say business model, every stakeholder in the ecosystem must have a return on his investment. So the day we solve this problem, and one of the things which America has done to solve this problem is insurance. Government of India has authorized the IRDA to recognize reimbursement for teleconsultations, but I don't think it's been implemented yet. So the day when teleconsultations are reimbursed by insurance companies, that day, I think telehealth will take off in a very big way. I think we will close down unless there are any final remarks which the panelists want to make. Please, Mr. Gautam, some closing remarks.
So, Dr. Ganapathy, only after hearing all the panelists and you, I am actually now more excited and more energized.
That is what Financial Express Health Summit wanted to. The organizers have taken all this trouble purely to ensure that everybody is not just excited, but implement and transform their excitement into practical work. That's what Financial Express wants, and I'm sure we have achieved that. Yes, sir, go ahead.
I think so. So I'm pretty energized, and I'm very happy that our thoughts are matching. It's like when everybody is thinking on the same lines, it's not a question of if it will happen, it's a question of when. So it will be.
It's not even a question of when, it's a question of now.
Now, it's a question of now. It's going to happen. So anyway, thanks to everybody, and I hope that next time whenever we meet, when we say Telehealth 3.0, we would look and see major progress from where we are today. So thank you everybody.
Thank you. Yes, Manish.
No, I think
people like you and Naresh are the future of this country. We are all, at least I am the setting sun. You are the rising sun. So please let us have your views.
I think experience and energy both has to go hand in hand to make any lasting change. So really looking forward to experience and support from all of you. Yeah, I think, in Telehealth 2.0, I mean, apart from the medical science and doctor, I think technology also has to play a very important role, because it has to be very, very convenient for each and every stakeholder to actually go ahead and, do their part. I mean, be it e-prescription. I mean, I see my dad also. So it's not very easy to go ahead and type, simple keys on the computer, right? So what can be done to actually make things easier and simpler? And I think that's a huge stride has been made on that front in terms of the system, the forms for e-prescription becoming more and more intelligent based on diagnosis and the previous history. Can the system recommend to the doctor that these kind of medication you want to write, and many more like that. So I think once it becomes a lot more convenient for every stakeholder, definitely we will see that the journey of Telehealth 2.0 to Telehealth 3.0 is going to be shorter than what it was from 1.0 to 2.0.
Thank you. Thank you. Yes, Naresh, you have the last word, because ultimately it is medicines which make, and a doctor's prescription is of no use. My making a brilliant diagnosis of a temporal lobe seizure is no use unless the carbamazepine I prescribe is actually given to the family. So you have the last word, Naresh.
So thank you, sir. More than medicine, actually, we are very, very excited. And I think today's this meeting also, I think, brought a lot of good energies. We want to be a healthcare company where we really, really want to augment the efforts where for primary and secondary care, the population at bottom of pyramid should not move towards tertiary care centers. Our tertiary care centers should be kept free for tertiary care. I think as Manish was also talking, Dr. Gautam also spoke about it, as technology can play a big role where we can probably business modeling, we will go through your paper also. We are very keen to understand this combination, how these internet operated devices, all IoTs and this technology can use at low bandwidth. You can transfer the data and you can create a business model out of this. We are very keen to understand this, where that masses for primary and secondary care can be treated at bottom of pyramid itself. And we then recommend them to, for tertiary care, they go to their medical colleges. One more interesting takeaway which we could get today is that public-private partnership. Normally, this corporate world, maybe if I'm a pharma company, if you're a hospital, you will go to government, and I think you will have the public-private partnership. But here, what interesting thing I see is, as you said, NDHM has announced there is no difference between public and private data. So they will create that common university. I think this will be very, very helpful, where both the sides of the doctors will be available for each other, both the sides of population will be available for each other for the better outcome. It's very, very exciting and quite a lot learning for a pharmaceutical industry guy. So to transform towards healthcare. Thank you.
Thank you. I'm sure I speak on behalf of all the other panelists. Thank you, Financial Express, for organizing this session. I hope the message will go across. If you ask me what is my take-home message, I would like to conclude with just 2 sentences. Today, distance has become meaningless and geography has become history. It doesn't matter where you are. It doesn't matter at all. And incidentally, telemedicine did not start in 2021. I don't know how many of you know that the world's first telephone call made by Alexander Graham Bell on March 26, 1860 was a call for help. He spilled battery acid on himself and he said, "Watson, come here, I want you." So the world's first telephone call was a call for help. So telemedicine is not something which has started this decade, not even this century, not even in the previous century, but it started in the 19th century. Thank you once again. I could go on and on. I think we will conclude at this. And thank you, Financial Express, for organizing this.